Hello, I'm Jess Berry from Children's Hospital Los Angeles and the University of Southern California. I'd like to thank the organizers for inviting me today to discuss liquid biopsy applications for retinoblastoma, from diagnosis to prognosis of ocular salvage. These are my financial disclosures. As we all know, unlike most tumors, retinoblastoma is not directly biopsied, and this is due to concern for extraocular tumor seeding. However, while we're still pretty good at looking into the eye and diagnosing this disease, a lack of biopsy does have some real-world clinical applications. First, for the management of this cancer, we have a complete lack of eye-specific diagnostic and prognostic molecular biomarkers. Much of this is subjective and relies on the clinicians looking directly in the eye. We have a lack of any personalized treatment plans because we are not using these molecular biomarkers to inform our care of this cancer. And finally, we have almost no understanding of in vivo tumorigenesis, by which I mean how these tumors change on a molecular level under therapeutic pressure. This changed when we took the new opportunity afforded to us by a safety-enhanced mechanism for the treatment of seeding in retinoblastoma. As part of intravitreal injections, aqueous humor was taken, and multiple studies have now shown that there are no documented cases of extraocular spread. And we aimed to investigate this new opportunity to discover whether or not the aqueous humor could be used as a surrogate to tumor biopsy, or rather a liquid biopsy for retinoblastoma. And in 2017, we published our first proof of principle paper demonstrating that the aqueous was a valid and effective biosource for liquid biopsy. So what is liquid biopsy? Of course, it is a biofluid. It can be CSF, saliva, urine. Frequently, it is blood, or of course, in this case, aqueous humor. That's a mix of cellular and non-cellular components that are derived from the tumor, but not due to a direct tumor biopsy. And while a tumor biopsy can give a snapshot in time of what's going on at the molecular and cellular level, a liquid biopsy really gives a more comprehensive evaluation, given what we know about heterogeneity in tumors and multiple tumor clones. And this, of course, is important for retinoblastoma. And finally, another advantage of liquid biopsy is that it is repeatable during treatment course longitudinally, so you can see the ways in which this tumor changes over time. There are two main mechanisms for detecting tumor DNA, and I think it's important to just briefly go over them. The first is whole genome sequencing, where you sequence small little pieces along the genome in order to identify whether there are areas of too many or too few chromosomes. It's known that tumors co-opt this chromosomal machinery in order to grow, and this is also well established with retinoblastoma. And so these chromosomal alterations prove that the DNA is tumor-derived. Another mechanism is to directly, deeply target the RB1 gene, looking for any mutations, which would obviously be suggestive that that DNA is also tumor-derived. These are two separate mechanisms, kind of in the same way that we do an examination under anesthesia to look into the eye, as well as neuroimaging to get an idea about optic nerve invasion or CNS disease. Different mechanisms to find tumor DNA, just like different mechanisms to diagnose retinoblastoma. Our research so far has allowed us to answer some really important questions, and I'd like to go over them with you now. The first, of course, is the big one. Is there tumor DNA in the aqueous? We and others have very clearly shown that the answer to this is yes. At this point, we have multiple years of data and over 200 samples. We've been able to standardize our methods for collection, handling, storage, and processing. Greater than 80% of the DNA in the aqueous humor appears to be tumor-derived. And in fact, in our hands in our laboratory, 95% of samples have DNA, 80% of which we've shown to be proven tumor DNA. However, we actually think that that number is probably higher. And as patients are treated, there's less DNA in the sample, but with deep sequencing, you could still identify RB1 tumor DNA. And in fact, we also looked at diagnostic samples or samples taken at the time of diagnosis under research protocol from eyes that are then treated with intent to salvage. And in these patients, 100% of samples had proven tumor DNA, either by the detection of RB1 mutant DNA or these chromosomal alterations, or both. Can the aqueous humor play a role in diagnosis? The answer here is also yes. As we've discussed, our lab and others have shown that with this DNA, there's a high enough concentration in the aqueous humor to reliably and accurately identify the specific RB1 mutation or mutations, if there are two, as well as to identify loss of heterozygosity with high fidelity in these samples. Our lab has also shown that you can do that as well as the genomic alterations from a single 100 microliter sample. This diagnostic biomarker then leads to lots of other clinical questions we could consider, like what do you do when you lose the view, the rare but persistent diagnostic dilemma, and can we use this to direct need for further adjuvant therapy, like when to start or stop intravitreal injections? Can the aqueous humor liquid biopsy play a role in prognosis for saving the eye? This is most exciting to me as a clinician who takes care of these patients, and so far our research suggests the answer is yes. This really comes to me from my clinical work, and so I think many of us have had the experience of two patients who look exactly alike, are treated more or less with the same regimen because we don't personalize it, and one patient will do very well, the eye will respond beautifully and be saved, while the other will have persistent or recurrent disease in the eye until finally they succumb and require secondary enucleation. So can we use the aqueous humor and the ability to detect tumor-derived biomarkers to predict this better? And so we directly assessed that in two papers, the most recent published in 2020 in Molecular Cancer Research, looking at 50 eyes with over 100 aqueous humor samples and matched tumor samples. And we were able to compare two groups, those that were saved and those that were enucleated. This had not been done previously outside of the aqueous humor research because before you only had tumor DNA from enucleated eyes. But by this novel ability to compare these groups, we were able to identify very clearly here the difference in gain of 6p, so chromosome 6p there, which was not only more commonly found in the eyes that failed treatment and required enucleation, but the amplitude or the number of copies of 6p was higher. And so if we look at what we all do right now, which is clinical prognostication, of course, our group D in green and group E in orange here eyes do worse. In our hands, our salvage rates were about 62 and 33%. But if instead of clinically prognosticating, we use this molecular biomarker and prognosticate by the gain of 6p, only 9% of eyes that had 6p gain in the aqueous humor were able to be saved. And the risk of treatment failure requiring enucleation was 10 times increased in those eyes. Can the aqueous humor play a role in monitoring therapeutic response within the eye? Again, the answer is yes. We've been able to show by looking at tumor fraction, or the percentage of tumor-derived DNA in the aqueous humor, that eyes that have a drop in tumor fraction show very nice tumor response to therapy and are salvaged. Those that do not have a concomitant decrease in tumor fraction tend to be enucleated. And most exciting to me, those that drop and then raise, so have an increase in tumor fraction, that portends an intraocular recurrence of this cancer before the clinician was able to notice a change, as you can see in this case here from 5 to 6. Does blood play a role as liquid biopsy? The answer is yes. There's been very exciting research around the world, and some of the most exciting has come out of Sloan Kettering, looking at the use of blood. In this case, whole genome sequencing is not done, but rather this targeted sequencing of RB1 mutant DNA, which you can do down to very, very low tumor fractions. The biggest question to me that remains unanswered in the setting of blood is, what does a negative blood test mean? Published studies to date have shown that at diagnosis, about 50% of eyes do not have any detectable RB1 mutant DNA in the blood, and during therapy, 60% or more of eyes don't have that. So we as a community will have to decide, how do you apply a negative blood test in these settings? Can you just use the blood? In my opinion, the answer is no. We evaluated aqueous humor and blood side by side for the ability to identify these chromosomal alterations using whole genome sequencing, and found that only the aqueous reliably had a high enough tumor fraction for this. We didn't say that you couldn't find circulating tumor DNA in the blood, but rather that the aqueous humor was superior because of its higher tumor fraction. Not only was it superior due to higher tumor fraction, but remember, 40% of patients with retinoblastoma have both eyes affected. Therefore, an organ-specific or eye-specific liquid biopsy is important. This is illustrated here in a patient with bilateral disease, group D in the right, group B in the left. That gain of 6P is here in the right eye, and you can see that there's differing biomarkers and chromosomal profiles between the eye, even though, of course, this patient has the same predisposing RB1 mutation. None of the chromosomal alterations were found in the blood due to the lower tumor fraction there compared to the aqueous. Finally, are there other eye-specific biomarkers in the aqueous humor? The answer is yes. I'm not going to get into the details of this, but we found extracellular vesicles, microRNA, proteins, and a whole plethora of very interesting research venues that show that the aqueous humor may be able to inform our care in a really personalized and predictive way for the treatment of retinoblastoma. For those of you that are interested, I think there was a really nice review on analysis of cell-free DNA for retinoblastoma in both the aqueous humor and the blood. This was published in Cancers by Amy Jarish, who's a scientist working in this field, and I thought it was nicely done. I don't do this work alone. I have a wonderful liquid biopsy laboratory team that helps me, and so I would like to thank all of them for their work, as well, of course, as our grant funding sources. These are my citations, which I'm happy to share with any of you, and thank you again for having me today.
Thank you very much. Very nice insight. Swati will discuss.
Thanks, Jesse. As always, I think every time I listen about this talk, there is always something new that I always pick up. So thank you for that. So I'm sure there are a lot of questions that are there related to this topic, because I think we are moving in the direction of personalized care for retinoblastoma for each patient. So I think the most important question that I would ask is, I know that you started off with doing the testing on the aqueous that you take while doing the intravitreal injections. At this point of time, we know that there is enough evidence that the aqueous is definitely useful to prognosticate the eye. So are you doing, even in those cases where you do not do intravitreal, just for getting a sample from the aqueous to prognosticate, are you doing that?
Swati, that's a great question. And yes, we are. So we have a full IRB approved protocol. It is, of course, a research protocol whereby we take aqueous at the time of diagnosis, as long as the chamber is formed. If the chamber is shallow, then we would take aqueous after the first cycle of IAC or systemic chemotherapy, whatever we choose for the patient. We take aqueous also at the end of chemo, during any intravitreal injections, and 6 months after the end of all therapy, in order to prove that the tumor is completely treated and there is no residual disease within the eye. I can actually just share with you, we were at ARVO, and so I was able to meet with my team. We now have 25 eyes from which we took aqueous humor at diagnosis. In those 25, we have 23 of them have detectable RB1 mutations. You know what both hits are because the tumor fraction is high enough to tell you. So you either have both RB1 mutations, or you can show that there's been loss of heterozygosity or a microdeletion, for example, of the RB1 gene on 13q. We also can detect the molecular chromosomal alterations for all. Now, in the two eyes that we did not, they were group A. We had multiple group B eyes. So even in tumors that are 3 millimeters, we can find this tumor DNA in the aqueous humor. And in multiple of these cases, it's a single patient with bilateral eyes, and we can show the difference between the eyes as well, which was recently published. So it's been very exciting. The diagnostic aqueous humor has a much higher concentration, and you can get really rich molecular information about the tumor from it.
Yeah, thanks, Jesse. So I can wait for much more information coming out in various publications in the coming months or years, I would say. Thanks for that. So my next question would be, now we know that I think there is evidence that retinoblastoma not only occurs because of, we are basically studying the somatic copy number alterations in the aqueous and the somatic RB1 mutation, but how do we, is there any way that you're also looking at the epigenetic dysregulation that is actually causing, like, the retinoblastoma? Is there anything that is being done in that direction for the epigenetic changes?
Yes, Swati, you're so on it. I didn't prime you with this question, I promise. We have a paper under review right now looking at that, and we did publish this data at ARVO. As expected, the methylation signature that you can find in the aqueous humor is nearly 100% concordant with tumor. That makes sense, right? We're looking at the methylation of tumor DNA, so we would expect it to be concordant. It's further proof that the aqueous is a really viable and I think now proven alternative to direct tumor biopsy, which we can't do anyways in this disease. We've been able actually to show there's some very good work talking about signatures of high risk or more aggressive retinoblastoma versus low risk. And, the criticism, it was actually beautiful work, but the criticism of that work was, well, but yeah, you can't tell until the eye is enucleated, which was true previously, but now you can tell at diagnosis whether or not these patients have a certain signature of methylation. We're looking at validating that methylation signature again for high risk aggressive retinoblastoma versus low risk retinoblastoma. And I think that along with 6P, as well as maybe some specific RB1 mutations will all give us really interesting and informative information about which tumors are likely to be good or bad players. Other things to think of here, right? MICN. So our platform can very easily identify MICN amplification. We've published that. And Francis's group has published that. I see he's on here. Hi, Dr. Munier. And so that's quite clearly available. And think about some other oncogenes. So we have some patients that we've identified either MDM2 or MDM4 amplification, other known drivers for retinoblastoma. Again, 5 years ago, you would never know that until the eye was enucleated, but we can now identify these. So I really think we are at the cusp of starting to identify what specific drivers are are driving the tumor in each eye. Okay, the MDM4 amplification was in one eye and not the other of this patient. Why they are important, and move forward with actionable targeting of these alterations.
Thanks, Jesse. Great information. I'll just, if I may ask one last question, Dr. Honauer, do I have time for one more question? Yeah, thank you. So I think there's definitely great evidence that you have provided that chromosome 6p gain or even the MICN amplification, as all of us understand, has a poor prognosis. Now, what do you do in eyes that you detect that with your aqueous biopsy, you detect that the patient has chromosome 6p gain, and we know that by evidence that you have shown that it increases the risk of enucleation 10-folds. So how do you go about treating that patient? Would you advise enucleation, go for enucleation, or would you just continue the treatment that you're doing with just counseling the parents? How do you go about it?
It's a great question, and it's one that I struggle with as a clinician all the time, because of course I have a clinician and a researcher hat, so I know this. We are very strict right now that because this is research protocol, we aren't acting on the information right now. The 25 diagnostic eyes that I just mentioned are going to be part of a prospective validation. So we've shown this association with 6P. We've shown that was at the time of intravitreal injection. We now are looking to prospectively validate that 6P at diagnosis has that same impact on treatment failure. So right now we would continue our routine current therapy and salvage eyes that we think it's safe to salvage. I will tell you that we have some patients with bilateral 6P as well. And so I think that plays a role in terms of decision making. And I suspect we will come to a place, we talked about classification. just like with melanoma, I think we will get to the point where both the clinical features as well as the molecular features of these tumors come together for a more comprehensive classification of eyes that are safe to treat and how to treat those eyes. So we're working on it.
Thanks, Jessie. I can certainly see that one day in the classification system, we would certainly have what is the aqueous humor results as well to classify the disease. Thank you for a great learning as always. And thanks, Dr. Power. I think we can move on to the next session. Thank you.
Thank you both.